Hi, welcome to the Children and Young Persons Improving Access to Psychological Therapy Enhanced Evidence-Based Practice course. Today I'm going to tell you a little bit about the value of our Enhanced Evidence-Based Practice course with the university. We're going to talk a little bit about how the EEBP course helps to bridge the gap with the Child and Wellbeing Practitioner course that's newly on offer with the university. We're going to address the value of low-intensity cognitive behavioural therapy and think about the flexibility that EEBP has within that. And we're going to think about the course, the staff involved, and the impact, and show you a few of the testimonials that we have from our previous cohorts of EEBP. Okay. So the first place to start when thinking about enhanced evidence-based practice is the need for intervention that we have for young people. Now, a lot of this you will cover as well within the Child and Wellbeing Practitioner course, but just to reiterate that 1 in 10 children need treatment for mental health problems, that's 10%, and that mental health problems result in lower educational attainment. So what we know is that children with conduct disorder are twice as likely as other children to leave school with no qualifications. We know that mental health problems are strongly associated with behaviours that pose a risk to health, so whether that's smoking, drug and alcohol abuse, or risky sexual behaviour. And that really significantly, 75% of mental health problems in adult life start by the age of 18. Moving on to childhood anxiety, we know from the research that 70% of children between the ages of 8 to 13 worry, so a vast majority of children. Now, the intensity of that worry tends to determine whether or not they access clinical services. Now, we know that prevalence studies show that 4% of children aged 5 to 15 meet the diagnostic criteria for severe anxiety disorder, but by the age of 16, this has risen to as high as 20% and continues to climb in the future. We know that comorbidity with other disorders is commonplace, and that anxiety disorders that go untreated tend to persist. So young people with anxiety disorders are 3 times more likely to have an anxiety disorder into adulthood. We know that childhood anxiety is also linked to educational underachievement and illicit drug dependence in adulthood. Thinking about depression now, we know that we can see from the ages of 11 to 15 there's a steady increase in rates of depression. But significantly, between the ages of 15 to 18, there's a massive increase in the prevalence rates of depression, and this is a critical intervention period for us. Now, thinking about the costs of young persons' mental health, it's estimated that between 11,000 to 59,000 roughly annually per child is spent on mental health difficulties. And that actually, if we look at a lifetime cost of 1-year cohort of children with conduct disorder, we're looking somewhere in the region of 5.2 billion. Now, how is that made up? So some of that is about actually the costs of conduct disorder that continue into adulthood in terms of the crime associated with it. And we're looking at the cost across various agencies, so health, social services, education and justice. Now, we know that evidence-based practice has substantial clinical and cost benefits, and yet only 6% of the current spending on mental health goes to services aimed at children and young people. So you're looking at an absolute overwhelming need in terms of prevalence and a massive saving in terms of costs for the intervention. If we look at the actual percentage of anxiety or diagnosable depression not in contact with mental health services, we can see that it's still quite high in adults, even at 35%. But if you look at 5 to 15-year-olds, 76% of young people with diagnosable depression or anxiety are not in contact with mental health services. And why? So it's been identified across the research that there are many challenges facing children's mental health services, and the 3 broad ones fall into lack of information on services, so there's no coherent data collection or incentives. We're talking about treatment gap, so we're talking about that 25 to 35% of children with a diagnosable mental health condition access support, whereas then we're talking about 75 to 65% of children haven't. We've got difficulties in access, so the NHS benchmarking and audit identifies there's an increasing demand, waiting times and complexity. EEBP thinks about how do we bridge the gap between access to services and young people not receiving services. Now, we know that many organisation structures have evolved to respond to crises and high need, and that there are other third sector and voluntary organisations who are doing great work, but they're isolated and not joined into statutory services. Now, if we use an analogy for a second and think about young people's emotional well-being as a bathtub, and bathtubs are usually associated with relaxing experiences. But as they grow and as young people experience more and more, we're filling up this bathtub to the point where we get to the point where we might be overflowing. So how do we get to the point where young people can be considered like a nice, relaxing, full-up bathtub without overflowing, where our response tends to be this? So previously, or in statutory services, we're the ones trying to kind of catch the falling ceiling from the overflowing emotional well-being. And this is where EEB comes in. EEB can be, and is, the kind of ability to pull the plug, not on people's emotional well-being, but on the overflowing sense. And why? Because low-intensity cognitive behavioural therapy aims to get in there early. We're looking at preventative emotional well-being. We're looking at building resilience in young people so that as they grow and they continue to experience difficulties, the support that can be in there early can help them to develop the resilience around those and learn the skills to stop that difficulties with emotional well-being turning into long-term mental health conditions that we know happen in untreated young people under the age of 18. We're talking about mild to moderate presentations, and we're thinking about young people being really goal-based and setting their own, putting them in the driving seat of their own emotional well-being so that they set the goals and that's the work that we do. So it's really focused. We're also using routine outcome monitoring, not just to measure symptoms and symptom change over time, but also to measure goal-based outcomes, so for young people to see what they're working towards. And we're also using outcomes around therapeutic alliance stuff. So we're constantly measuring how are we doing, how are you doing, how's it going. And the interventions are brief, so we're not talking about high intensity longer term, we're talking about brief, we're talking about empowerment, and we're talking about preventative mental health. And they're based on evidence-based interventions. Now, EEB sits in a position much like the child and wellbeing practitioners, where we can stand to join up the voluntary and statutory services for a coherent provision. And in fact, when you look at our previous EEB cohorts, the professionals that joined us were from a wide variety of services, from physical health to emotional wellbeing to primary mental health workers to school nurses, and also voluntary counsellors. And that's what is the beauty of low-intensity work in trying to join up these services and bridge the gaps. Now, we know that there is a fragmentation currently in services. There are pockets of great work, but they need joining up. And this is where EEB and CWP come in helping to address this fragmentation through really building skills in EEB and CWP practitioners in coordination and signposting. So they know what they're able to do, they know what their role is, and they know what other services are out there and they can signpost on. And that helps to bring services together in a really collaborative way. Now, our practitioners, as I said before, are drawn from statutory and voluntary services, and there is a real beauty in how they come together in the learning sets to really share good practice and what it is they do as services to actually really improve that collaboration. Now, EEB, unlike CWP, is about transforming existing services, so working with the professionals you already have rather than employing new ones. And it's about broadening the skill set within your existing services. But we're able to intervene earlier, we're thinking about stepped care and accessing evidence-based treatments, which we know from the research where we work. We've talked about being outcome-led, and it's a fundamental foundation for EEB and CWP that we work on knowing how it's going, knowing what's working, and refocusing if it's not. So there's a constant monitoring over time. We want to be able to provide service coherence and actually sustainability for the new child and wellbeing practitioners, and the EEB can help to bridge that gap between the two. And we're talking about facilitating child and young person's preferences for treatment models. So really putting them back in the driving seat, really following what it is that they want to achieve, supporting them along the way. We talked about this a little bit, but just wanted to revisit who have been our EEB practitioners over the last two cohorts. We've had school nurses, we've had paediatric nurses, we've had voluntary counsellors, primary mental health workers, specialist OT, youth workers, school counsellors, and all of these people are in perfect positions, not only within statutory services, but also within wider community child and adolescent mental wellbeing services, to really be able to see young people further up in their journey and their emotional well-being and are best situated. So there may be some of you who are wondering why we have an enhanced evidence-based practice course and a child and wellbeing practitioner course when understandably and in many levels they kind of work towards the same goals. And I don't even think it's a question that should be being asked in terms of which one do you choose. There is a gap for EEB, and there's a place for EEB in actually helping to provide the integration and the coherence of a child and wellbeing practitioner programme. Because arguably a lot of the EEB practitioners have core professions previously and are sat sometimes in the statutory services, and they can bring a whole different outlook to the work that they do. So you're expanding their skill set. Now with EEB we can deliver flexible, brief face-to-face interventions, and this can be across 6 to 8 sort of brief sessions. We can do group and individual, but we're also fundamentally goal-based, and we're sort of thinking that EEB actually can help start bridge this gap between the low intensity and the high intensity in the opportunities for stepped care, where the CWPs can be arguably out there in much wider community services, and some of the EEB practitioners will still sit within the statutory services. And we're talking about continually developing the skills of existing staff. So what presentations? Much like the child and wellbeing practitioners, we're talking about mild to moderate anxiety and depression, panic, worry, generalised anxiety, sleep difficulties, simple phobia, stress, tension, low-level difficulties with anger, self-esteem, mild to moderate social anxiety, low-level compulsive behaviour, mild health anxiety, and assertiveness or interpersonal challenges. So when you look at this list, this is quite typical of some of the difficulties that school and even younger children start to experience that they're not currently receiving access to services for. And in terms of the interventions, we're going on evidence-based, so we're working with behavioural activation, relaxation, problem solving, cognitive restructuring, exposure and habituation or exposure and response prevention, worry management strategies, group-based parent support for young person's anxiety, so there's a Timid Tiger programme that's taught within EEB, and group or individual support for young person's anxiety, and that's Coping CAT, another programme that's taught on the course. And we're thinking about lifestyle management. Lifestyle management covers a whole broader idea range around sleep hygiene, diet, exercise, all these things that feed into kind of how we generally manage our stress levels. And in terms of severity, we're looking at low-level, mild to moderate, common mental health issues. We're not thinking about young people who pose a high risk to themselves or others, and we're thinking about mild to moderate complexity, and complexity is about the impact on daily living. However, we do know that it is possible to make gains in a more complex picture, as long as complex doesn't equal high risk. So thinking about future directions for EEB, now this is a broader national conversation that hasn't happened yet, but only now we're thinking about how we blend this programme with the up-and-coming child and wellbeing practitioners. So there is room for a conversation around the sustainability of low intensity and integrating child and wellbeing practitioners with EEB staff as well. So we're talking about CAM staff that come with an existing broad professional background. So they may already hold great skills in professional experience in autistic spectrum disorders, in neuro, in peds, in medical, that the child and wellbeing practitioners don't yet bring to their training. So there's an opportunity for your existing staff team to be able to broaden their own skills, but to also potentially link this gap between the child and wellbeing practitioners' practice and the higher intensity aspects across many different services. And we've got the potential to extend the curriculum to reach into these areas, but that is a national conversation for EEB that would be really interesting to develop. So in terms of the course, it's a one-year programme that results in either a graduate certificate or a postgraduate certificate. Now, those entering the graduate route need to have studied at level 5, which includes HND, foundation degrees, diplomas of higher education. And those entering the postgrad programme need to have studied at level 6, so that's about honours degrees, professional certificates in education, graduate diplomas, graduate certificates. There's 2 strands. In terms of the modules, And there are 3 modules which we cover. The first one is about context and values, so we think about participation, we think about diversity and culture, we think about the broad CYP IAPT principles that have become so embedded in how EEB practitioners will think about their work. So very much around making sure that children and young people are at the centre of everything that we do. And module 2 is about assessment and engagement, where they're really taught focused skills around low intensity assessment, structured assessment, and really strong engagement skills to make sure that the brief interventions that they're able to deliver, they're able to maintain the therapeutic alliance and maintain the focus throughout. And then in module 3 we cover the interventions that we've talked about before. They come and do this through a variety of ways. So there's university teaching and workshops that cover 15 days of the course. We use a lot of e-learning, so MindEd, that's already a great platform that's set up to support learning. And we have service-based learning days. Now these are an opportunity for practitioners to really take and consolidate the learning they've had in university and be able to apply it into their services and really address some of the links between service needs and the university kind of theoretical teaching. And then the supervision is provided by their service supervisor in service. Okay. In terms of course requirements, there's an allocated service supervisor within the service, so they need to be CBT trained or attended the supervision training or the outreach supervision training. They need to complete a minimum of 40 hours clinical work with a minimum of 15 hours supervision. The supervision is group format, so they have a minimum of 30 minutes each trainee, and they need to see at least 3 cases to completion, and completion is a minimum of 5 sessions for each. And they need to think about a minimum of 2 anxiety and 1 depression case. They need to demonstrate all the competencies outlined in the outcomes document, which is our kind of final document which really monitors the skill and competency development drawn from the CAMS competencies across time. So it's constantly assessed throughout their course. They'll need on average about 1.5 days a week to see clients and have supervision on top of the university and service talk days, which is 27 days in total. I just want to share with you some of the impact that EEB has had so far and give you some testimonials and some outcome measures from what's happened before. Now, in our first cohort, one of our tutors and people on the team had a clinical psychologist working in paediatrics come up to them and actually talk about how she'd experienced the impact of EEB firsthand. That they had, that when they'd seen a family that had been referred to see her, they did such good work that at the end of it they actually didn't need the referral to the clinical psychologist, and that's a massive result, really. We're talking about that's exactly what we want to happen for EEB. We want to get there earlier and to try and prevent the need for stepping up. Now, in terms of cohort testimonials, this testimonial came from a counsellor who, and as many of our cohort have been previously counsellors, and they've always had this learning journey of being able to integrate structured, evidence-based practice alongside the great skills that they have in counselling. And it's not an easy journey for many of them. But I think this testimonial gives a real sense of actually the value that they've been able to take from being able to hold both their brilliant counselling skills and their low-intensity CBT skills and be able to use them interchangeably depending on where the young person sat. I just want to pull out a couple of the outcomes that came through from the practitioners' competency training over time. And this was a sort of before and after picture for somebody working with anxiety. So you can see on the left-hand side of the screen that at 14th of March 2015, the first outcome measures demonstrated quite a high level of separation anxiety and panic, and those were the defined kind of goals that the young person wanted to work on. And then when you compare that to the 15th of July, you can see that they are now clinically underneath the line. So they've had a really vast improvement in their symptoms over time. And this is the same client, but with a slightly different graph. So on the left-hand side of the picture, depending on whether you're facing or turning away from it, but the arrows that go from high to low show exactly the difference in time between 14th of March and the 13th of May. So you're looking at significant reduction in social phobia, significant reduction in the major depression scores, and also significant reduction in the separation anxiety scores. And on the other line moving up is about goal-based outcome progression over time. So you're looking at an increase in improvement in how a young person has met the goals that they've set themselves. And I just wanted to add in this because it's really important to hear the young person's and parents' voice. This was a note sent to one of our practitioners having completed work in a low-intensity basis. And they say, just a note to say thank you for all you've done for the client. Your intervention came at a time when we were desperate, and now the client's come so far, it's wonderful. Good luck with all you do in the future. And this is really commonplace. So when you go through the kind of competency and the evidence that EEBP practitioners draw from in order to evidence how they've done over time, these kind of testimonials from children and young people are really commonplace to see, and it's lovely to see that EEBP is doing exactly what it set out to do. It's getting in there early, it's producing great results, and I think that's a fabulous investment for any service. Okay, thank you for your time today, and I'm sure all of our colleagues here will help you to answer any questions you have about EEBP. Thanks.